Hello everybody, my name is Naveed Sattar. I am Professor of Cardio-Metabolic Medicine at the University of Glasgow in Scotland, and I'm here at the ADA in New Orleans in 2026, and it's a pleasure to speak to you. Oh wow, okay. It's always a privilege to get prizes or awards. I don't take it too seriously. I think it's nice to get the award. But it's a testament, as you know, as everyone knows, that often it's not just about an individual, it's team effort. So we share the prize, share the honor with all of my team, all of my many colleagues who have helped me understand things better, or the juniors who have worked and have improved knowledge in a bi-directional manner, and also our patients who teach us many things over the time. It's good also for our university, is that we are a fantastic university in Glasgow. I think we have some of the world's best cardiologists, John McMurray, Mark Petrie. We have some wonderful juniors. It's a great privilege to be part of that and represent the metabolic arena. The key thing in research is to maintain your integrity, maintain your honesty, look at data properly, evaluate it properly, give fair and honest judgments. And when you do that and you are able to look at evidence in that manner, people respect you, but you're also then doing the best you possibly can for your patients. And ultimately, being a physician is really about the health of our patients. And if we stay true to that, then other things follow, like sometimes nice prizes. So thank you very much. Major cardiovascular outcome trials, particularly with SGLT2 inhibitors and GLP-1 receptor agonists, have told us that there are major gains to be had by having hemodynamic benefits, so removing excess fluid from the system, and also gains to be had from a GLP-1 class of drugs in kidney disease, but also from losing weight in patients with heart failure and HFpEF. So there are multiple benefits for this class of drugs in patients with cardio, kidney, and metabolic disease. Of course, we know that big weight loss is a major benefit in people with diabetes. And of course, we also know that the GLP-1 trials are showing atherosclerotic benefit, as well as kidney benefit, as well as heart failure benefit. So we have two classes of drugs that seem to affect several diseases which are relevant to many of the patients we see. For many years in diabetes, we have focused on glycemia. About 20, 30 years ago, we also started to realize we have to focus on lowering lipids, particularly LDL cholesterol, to great benefit, as well as treat blood pressure. So we've had really a triple-pronged approach of glycemia, blood pressure, and lipid improvement. What we neglected to realize that many of our patients living with type 2 diabetes also were living with obesity. And obesity is a major risk factor, not just for the development of diabetes, but it's a major contributor to their hypertension, to the patient's dyslipidemia, and as well as other aspects like potentially thrombotic tendency, systemic inflammation, but also how the patients feel, their risk of other comorbidities linked to obesity, such as sleep apnea, and fatty liver disease are also linked to obesity. So this has now been recognized over the last 2 to 3 years in some guidelines. And I think even now at this American Diabetes Association, it's pretty clear that targeting obesity should almost be the first line intervention in many people living with type 2 diabetes. And that revolution has started a few years ago, and it's continuing very fast now going forward. So, summary, target the obesity. We now have tools to allow us to do that, such as GLP-1 receptor agonists, and I think this is the direction of travel for future care of people with diabetes. It's been a privilege to be on guideline committees. When we are in guideline committees, we have specific rules of how we grade evidence. the highest quality of evidence is where we have highly robust randomized trials that show benefit for a particular class of drugs. And if we have a consistency of a number of trials showing the same benefit, then clearly we get the best grading for that particular product. We recognize also that not all interventions have that level of evidence. For example, lifestyle. We have very few major lifestyle intervention trials, but that does not mean to say that lifestyle is not important. So as a committee, we have to look at all the evidence for all the classes of drugs in different areas, look for where the evidence is best, and also then make pragmatic judgments of how we apply that evidence and how we explain that evidence in simple algorithms, simple tables, so that our colleagues around the world can understand what they should do with their patients, at what stage of the disease, and what interventions they should use, and back it up with the quality of evidence to give them confidence to do that. In addition to looking at evidence, we look at evidence not just for the benefit of the drugs, but also the safety of the drugs, and in whom those trials have been done, what patient population, was it secondary prevention, was it primary prevention? And a really important part of the guidelines is also to explain what the gaps in evidence are that we need to fill for future benefit to improve the guidelines in different groups. So it's really about high quality evidence, rigorously evaluated, translated into a meaningful, simple guideline that clinicians can follow, and then continued education for all clinicians so that we try to implement the guidelines in our patients. Some guidelines have also a consideration for cost, because we can't afford to do everything that's evidence-based on every patient. So if some interventions are very, very expensive, then perhaps we make some other judgments, but other guidelines do not pay attention to cost. So it depends on the guideline. But guidelines help improve care, and it's great to do them, and we should continue to do them. I think in the future, however, we will need guidelines that don't just cover single diseases, but cover multiple diseases at the same time, particularly now that we have drugs that affect multiple diseases at the same time, like SGLT2 inhibitors and GLP-1 receptor agonists.